Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Institutional Clinical Trial Accrual Volume and Survival of Patients with Head and Neck Cancer by Ivan Wuthryk et al. My name is Avraham Eisbruch, and I am a professor at the Department of Radiation Oncology, University of Michigan, Ann Arbor, USA. My oncologic specialty is radiation oncology. High patient volume is associated with improved outcome, including survival, compared with institutions with low patient volume. This has been established in many papers in surgical series, notably oncological surgeries, over the last 4 decades. This improved outcome has been explained by better expertise of the surgeons and by better supportive care in institutions with high patient volumes. Similarly, high-risk medical oncology procedures, such as high-dose chemotherapy and stem cell transplants, have better reported results when performed in high-volume institutions. While the benefit associated with high patient volumes when complex surgery or high-dose chemotherapy are performed is self-explanatory, the question of an outcome benefit when other complex procedures are undertaken, such as highly conformal or intensity-modulated radiotherapy, has not been well addressed till the present. The issue related to the complexity of modern radiotherapy include the need to accurately define the targets receiving high doses for macroscopic disease and targets at risk of subclinical disease in the vicinity of the primary tumor and in the non-involved neck, which is at risk of subclinical metastasis. The goals of highly conformal radiotherapy are to treat adequately the targets while sparing critical non-involved organs such as the salivary glands and swallowing structures, aiming to minimize urostomia and dysphagia and improve long-term quality of life. There is an inherent conflict between these goals. The more expensive the targets are, our ability to spare important structures is reduced. Physicians treating large number of patients may have gained experience in better solutions of defining targets versus spared organs than physicians treating few patients. In addition, the technical capability in planning radiotherapy, achieving the goals of target versus critical organ doses, varies between institutions and is likely better where there is substantial experience. Thus, physician and technical expertise gained by treating many patients may improve patient outcome. The article by Wuthryk and colleagues that accompanies this podcast provides the first evidence that high patient volume is associated with improved outcome after chemo-irradiation. The authors used data from a randomized RTOG study of standard fractionated versus accelerated fractionated radiotherapy, both concurrent with cisplatin. The primary aim of the study was not achieved, as no benefit was observed in accelerating radiotherapy. Wuthryk et al. Examined the outcome of different institutions participating in the study based on a surrogate for their patient volume, namely their accrual to the RTOG trials in the past, dividing these institutions to high and low accruing ones. They included only patients with non-HPV and smoking status and found that patients at low accruing institutions had better performance status and lower T stages, but were otherwise similar to high accruing institutions. Radiotherapy protocol deviations were significantly more prevalent in the low versus the high accruing institutions, notably a longer overall treatment time. The bottom line, patients treated in low accruing institutions had worse overall survival and disease-free survival even after adjusting to radiotherapy protocol deviations. What were the potential reasons for the better outcome in the high-volume institutions? Deviations from radiotherapy protocols, which may be related to relative lack of experience, have been previously found to reduce treatment efficacy in an Australian and a previous RTOG study. Better supportive care through a multidisciplinary setup, common in large centers, may not be available in small community hospitals. And intensive supportive care with attention to nutrition and hydration of patients may facilitate completing therapy within the scheduled time, minimizing extension of the total treatment time, which was found to be longer in the low accruing institutions, and is associated with reduced tumor control rate. Also, adequate supportive care may reduce acute morbidities, such as aspiration pneumonia and severe dehydration, which may cause early mortality during and soon after completing therapy. However, the survival curves provided in the article suggest that no difference in survival was detected between the two groups until later than 1 year after therapy, suggesting that better radiotherapy planning may have played a more decisive role. This is supported by the finding in the current study of higher rate of protocol deviations in low-volume institutions, 18%, compared to high-volume one, 6%, and higher local failure rate, 36% in the low-volume institutions versus 21% in the high-volume institutions, respectively. Weaknesses of the study include the assumption that institutions with low accrual to RTOG studies in the past have in general low patient volumes even now. This may or may not be the case, at least for some institutions. The authors argue that experienced providers likely execute superior treatment plans and may better support patients throughout treatment. This argument is supported by few previous studies of the outcome of head and neck cancer in large compared with small institutions, and by many studies demonstrating such benefit when complex therapies are required for other cancers. It suggests that specialization in the treatment of head and neck cancer, feasible in large volume institutions, should be encouraged. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.